Perfect. So without further ado, hello, bonjour, welcome everyone. My name is Robin D.B. I'm an assistant professor at Memorial University in Newfoundland and Labrador, and I will be your host for today's talk. I would like to welcome you all to this Lunch and Learn presented by CASN's Research and Scholarship Committee. The presentations in this series focus on cutting-edge leadership that create change. Before we begin today's talk, I would like to offer a land acknowledgement. CASN's national office is located on the traditional territory of the Algonquin people, and we would like to acknowledge and pay respect to the Algonquin people who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region and in all regions across Canada. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. So thank you all who have registered for this Lunch and Learn session. Lunch and Learns, as you know, are a popular tool in academia to encourage scholarship.
Hang on.
Faculty members, oh, can you hear me?
Yes.
There we go. If everyone joining, if you don't mind just muting yourself, that would be greatly appreciated. We have many members. We're lucky to have registered for this session. Thank you so much. So again, in terms of Lunch and Learns, faculty members come together traditionally during their lunch hour to share their work and to network. CASN's webinar series, presented by the Research and Scholarship Committee, aims to create the collegial feel of the Lunch and Learn and is intended to serve as inspiration and provide a networking opportunity. Nursing faculty from across the country present on scholarship projects and discuss methodologies, successes, or challenges they have encountered in their work. So please note that we will be recording today's session. You probably heard that voice before indicating that it was recording earlier. And we will begin with a presentation from our guest speaker and then provide approximately 15 to 20 minutes at the end of the talk for questions and answers. If you would like to submit a question, please use the chat function. If you prefer to vocalize your question, please indicate in the chat function question, and then we can call upon you to ask your question. So in this session, we will be hearing from Dr. Sally Thorne from the University of British Columbia, whose presentation is entitled Creating Change in Applied Qualitative Health Methodology. Dr. Thorne, it is an honor to have you join us today, and we look forward to your presentation. So over to you.
Well, thank you so much, Robin, and thank you to all of you for being here. I'm going to move very quickly into my presentation because we'll find that we've got limited time. Hopefully you can see that now. Okay. You've heard the title for my talk. And I too want to acknowledge that I'm speaking to you today from the traditional, ancestral, and unceded territories of the Squamish, Tsleil-Waututh, and Musqueam people, and reflecting on the stewardship about issues of positionality and land that we can learn by our continuous engagement in this process. I just wanted to start my own ideas journey that this talk will reflect on, as in some ways starting back with 1972. I'm of that sort of vintage of Toronto Western Hospital. This is me at that time. And as I look at that face, I think we can all recognize that someone who looked like that in Canadian nursing history did start off with some privilege in the sense of having the opportunity of education, not having barriers by virtue of visible minority status. And I have just had a lot of luck and wonderful mentorship over the course of my career, which continues even though I now am a professor emeritus. I continue to be editor-in-chief of the Journal Nursing Inquiry, and I'm very much continuing to be interested in research, which I'll talk to you a little bit about today. I also, way back in my master's program, had the opportunity to be closely connected with nursing theorists, which gave me some connections with the philosophy tradition as it was evolving at that time, that tension between nursing theories and philosophizing and understanding the ideas that shape nursing. So I had the advantage of some brilliant teachers, including Dr. Margaret Campbell, whose life ended far too early, but she had very big brain cells, as we used to say, and very much got us thinking about what is the nature of this thing that we call nursing. I also, starting my own career in 1972 and then my own graduate work in 1979, I really was watching an early part of nursing. If you'll recall, our own Canadian first nursing journal didn't start till 1969 at McGill. And nursing research, which was the first formal nursing journal in the US, didn't start till 1952. So you can start to see that that was still early days. And I really do feel that I had the privilege of watching some early developments in nursing thinking, including theorizing, research itself. Now, I wasn't there for the beginning of research, but this a little bit explains why I got involved in methodology at such an early point. Nursing was keen to become known as a science, to become recognized as a credible discipline, and to involve itself in research. But at that time, the only option was quantitative methodologies. And so the idea was to try and force fit the thing you were really interested in into something that could be measurable. And that was a complicated problem for many of us at that time, because the stuff we were interested in is often notoriously messy and complex and doesn't stay constant outside of its natural context. So when you were measuring something, you reduced yourself to a tiny little window on the totality of the thing that you were interested in. So there were some early nurses, and these among them, that kind of discovered qualitative methods. For the most part, it was nurses who had had the opportunity of doctoral study in social sciences, but they were recognizing that anthropologists and sociologists in particular had been using an alternative kind of method, because conventional the kinds of things we use in health science did not work particularly well for them either, and that they had developed tradition of building theory on the basis of qualitative methods. And so these were some of the early names of nursing research, qualitative nursing research. And I count myself incredibly lucky to have had the opportunity to work in various ways with them, to be in rooms and argue some of these issues of methodology. Okay. Well, there's a bit of an echo there. Okay, got it. So what we were excited about was qualitative methodology kind of captures the kinds of things that other science misses or misrepresents, that things that can't be quantified or regularized. And so it was kind of exciting to think that this new paradigm, we called it at that time, would be able to capture some of this work. And in those early days, you couldn't, you sort of had to stop believing in one religion before you took up the other. And there wasn't a sense that the same person could actually do qualitative and quantitative methodology. It was almost like a worldview change, a paradigmatic change to see the world from the perspective of a qualitative method. But the methods that we had came from disciplines that were entirely different and different purposes from the kinds of things that we're doing in nursing. And the methods were very purpose suited to the academic disciplines for which they were intended, and the rule structures, what the point of knowledge was within those rule structures. So we were always battling between not really being full anthropologists or sociologists or psychologists, for example, just drawing on those methods and trying to demonstrate that we had the right to use those methods, even though we weren't of that discipline, that nurses could actually take up these qualitative methodologies and do them properly. And we felt we needed to do that in those days, because the health science world, the conventional quantitative health science world, did not understand qualitative methods, and we needed to argue that what we were doing was social science. At that point, they'd say, "Oh, okay, we don't expect to know what that is. We know it's a legitimate discipline, so we'll let you have it." And nursing was really stuck in the middle, trying to meet both masters, if you will. And this really created a terrible methodological rigidity in which we would train up our students, or those of us who were learning, would be trained with an idea that you take a method and then you follow it rigidly, and that's how you create good findings. Even though Sadlowski early on pointed out the significant problem with that thinking, it did continue for quite a long period of time. And some of you may find that that's still a feature of some of your graduate classes, when which you encourage, for example, master's students doing a first thesis to pick a method and then follow it exactly, rather than using their brain, their nursing brain, to be able to make adaptations within that method. But I've been arguing for the last 25 or 30 years that social science and nursing are entirely different propositions in the world. They exist for different reasons to engage with the world in different ways. We really exist for the purpose of acting. And when we theorize, it's theorizing for the purpose of acting. And I realize that's a generalization, and you can pick apart generalizations, but I think it's a useful position to be sitting on to explain why we needed to have some alternative ways of thinking about method. We needed methods that were really aligned with our disciplinary epistemological hardware wiring. That means the way nurses come to know collectively, how nursing understands the world, what sorts of knowledge is relevant, how we use knowledge, and toward what purpose, and how we know if that purpose is meaningful or not. And so all of these aspects of nursing epistemology were written out of application of qualitative method. In fact, you wouldn't even really mention that you were a nurse. It was not really seen as one of those, the disciplinary ideas were not really seen as one of those relevant factors. Instead, you were, what tradition are you working within? What methodological or theoretical tradition? So I've been arguing, and I think my own particular history might explain why I had a fascination with it, that aligning methodology with that nursing epistemology would turn out to be really important. And just a few examples of what I consider to be nursing epistemology, regardless of what theoretical orientation you may or may not be using. All of the theories dealt with the idea of wholes and parts. We might focus on a particular aspect of an individual that's in pain or distress, but we're always doing it in the context of who that whole individual is. And our thinking moves back and forth iteratively between the injured part, for example, and the whole person. That ideal is constantly in operation in all of our thinking in nursing, in clinical nursing. We also do not only deal with common patterns in human behavior or human experience. We're very comfortable with the idea of there being common patterns to attend to, but we aren't worth our salt if all we can do is say what the average patient would experience in this situation. Our clinical minds need to be attuned to difference. We would never graduate a undergraduate nursing student who felt that all patients were the same. And if I've seen 10 patients with this condition, I don't need to learn anything more. The nursing mind is always attuned to who is this person in this moment, and what is it about this person that might require me to practice in a slightly different way today than I might have practiced with a patient with a similar condition yesterday. So the knowledge we need for practice is never just commonalities and standard protocols. It's always that capacity to understand meaningful difference that might shape our interactions. We're also not simply dealing with bodies, which is fairly obvious. We're dealing with experiences and ideas. Who is the person, and what have they experienced? What traumas do they come with? What fears do they come with? Where are they heading? What ideas do they bring into their engagement with our interaction with them and with moving forward? So the ideas and experiences of anyone we encounter are very much part of what we're attending to, regardless of where we're practicing. And we're doing all of this in a dynamic context of 20 other disciplines also having a role with our patient in this moment, and other processes going on. So we're understanding that what we do is not the singular intervention or action on a patient, but it's in the context of a lot of other things that we also need to understand, and we need to understand their impact. So when we're developing knowledge that aligns with our discipline, we're not expecting it's going to be factual or fixed. We're not coming up with the fixed truth on exactly how somebody lives with a certain phenomenon. We are contributing to an ongoing conversation about ideas. We recognize nursing knowledge is building and evolving over time, growing richer and in more depth, with more complexity and more possible opportunities for variation. So we see the research that we're doing in the qualitative context, or in our discipline, we see it as just contributing to that knowledge rather than coming up with a final answer. We assume that 10 years from now, nursing will have a better grasp on this phenomenon, will have more inputs, will be more things they could take into consideration. That has been the pattern of our knowledge development over time, and it will continue to be. So none of us are creating knowledge to have the fixed answer for all time, but we're creating knowledge to encourage that development of nursing thinking one step further. I'm going to mute somebody there. Okay. We're also doing this in the context of a world of believing in evidence-informed practice. Of course we do. So we are not ignoring the quantitative science and the discoverable facts. We are not ignoring the context in which we apply the wisdom that we have. We have to have the clinical knowledge and leadership systems to make that happen. And we need to have that qualitative science to be able to bring all three together into that thing that we aspire to, which is evidence-informed practice. It's not simply picking up the science and doing something with it, but it's putting it into the context of all of these together. So because this is a little bit about what I see nursing's sort of social contract and core values, that it's epistemological uniqueness. This is how we think as nurses. You can see how that would have created some methodological confusions if people were trying to follow a social science methodology literally and not allowing themselves to exert that nursing thinking. Just a quick example, and I could go on forever, but just one that I think will make the point that phenomenological tradition, and I realize there's many species, but at its core, it was asking the researcher to bracket all preconceptions of a human phenomenon that they too might have experienced as the research instrument, so they could get as close as possible to that idea of the essential nature of a lived phenomenon. And they were interested in things that they assumed were not only shared, but actually fundamental to human experience, such as the idea that we could experience grief across all human cultures, across time as far as we know it from the literary record, whether you speak the same language, whether you have anything in common, human beings can recognize grief. And so understanding those essential humannesses was the project of this original phenomenological tradition. And so they had lots of rules for how to create that. In nursing, however, we are always building on the disciplinary knowledge. We're not getting rid of anything anybody else might have written. We're saying what has been developed and how can we build that forward. So where the phenomenological question, the sort of core, straightforward, typical phenomenological question might look something like, what is the lived experience? Which even in its syntax suggests that there's a singular experience. We now, in nursing, would be asking questions that are much broader, like what can be learned from the experiences of. We're going to recognize that if we talk to three people, we'll get three experiences. And yes, they may have commonalities, but we can learn something from those differences. So just a little example of how the phenomenological tradition has sometimes led us, and rigid adherence to it, has led us to do and say things that we don't really believe. Because I can't believe that nurses would believe that there would be a singular experience, because the essence of our practice is that capacity to adapt to the variations that humans represent. So in the early years of qualitative research, there was quite a body of research that had a significant disconnect with the role of theory and theorizing, and was either doing too much generalization, like I've interviewed 6 people and therefore we ought to change the policy for the whole country, or too little generalization. I've interviewed people and my findings are only relevant to those people that I've interviewed. And in either case, you say, why bother? We can't find a logic to it. So that kind of research tended to sit on shelves and not be particularly useful. So nurses had great intentions, but much of the early qualitative research did not really meet the discipline's knowledge needs. Your colleagues in practice, for example, would hear the report from a qualitative study, particularly if it was ending up with a theory, and say, well, that's all very good, but I have no idea what to do with that in practice. How does that link and what can I do? And we needed to do some better thinking about how we formulate problems, what assumptions we bring in, theoretical resources, designs, and methodologies to really think about how we can use knowledge generation for applied practice. So that's the project that I've been on about that I still am very excited about. Started writing about it in my doctoral program. The first paper was in 1991, saying, you know, is there something wrong with this methodological orthodoxy? And is it creating some difficulties? And it was a paper I was advised not to publish, but you know, like any good doctoral student, if you're told not to go into an idea, sometimes that's what's most tempting. And I had no idea that it would end up being sort of a lifelong fascination. But over time, by observing when qualitative research in nursing was effective in creating findings that really spoke to practice and advanced knowledge, looking for patterns in that kind of research, I was able to sort of document what those studies looked like, because they did bring a nursing lens into aspects of the design and application of the design. So by characterizing those, I was able to describe them and called it interpretive description, which was in the first paper in 1997, was intended to be just a description of a kind of research. It wasn't intended to be a method. But what I learned early on was that in order to pass through ethics review panels, doctoral supervision committees, and external examiners, journals, grants, and that kind of thing, you have to have a reference point. That good nursing thinking and saying, I'm a great nurse and I'm thinking this through and I'm doing it my own way tends not to meet some of those expectations. So having a reference point to be able to say, I have legitimacy to be bringing my nursing angle of vision, my nursing epistemology into the justification for some of the design decisions I'm going to make along the way. I'm not going to follow a prescriptive method that somebody laid out for another project in another time. I'm going to be thinking throughout the whole study of what would make sense in my study, what modification might make sense. So in other words, in good nursing fashion, this is sort of emancipation from social science, taking the technique without the theoretical baggage, building in the idea that what we're doing is for someone. It's for that clinical world, that nursing audience, or that educational world, whatever it is that's our end user. We're aware of that from the beginning. So we're building in that knowledge translation into why we're doing the study, how we're doing the study, and all of the aspects of what happens afterward. So it's not simply just conducting a study then, but a hardwired commitment to why we in nursing do research and staying true to that through the design. And over time, we're not simply studying things qualitatively, like what's the lived experience of a certain illness, for example, but we're really interested in how we get at things like individualized human experience and build them into our protocols and algorithms. We're very interested collectively across this country in equitable access to healthcare and equitable quality of health services, impact of social determinants on health, critical deconstructions of the assumptions and ideas that shape healthcare, and various emancipatory and participatory kinds of projects. These are the sorts of things that draw us in qualitatively. This isn't an inclusive list, but it's just showing you that we have different reasons for wanting to do research than simply to be building grand theorizing about how human beings are socially organized. And we also need to make sure that in using our qualitative methods, we're not making the same errors that quantitative research has historically made, and the kinds of things that it missed. Specifically, I'm thinking about populations at the margins, those populations who have not been well served by setting up systems that fit the needs of the dominant majority and sort of assume if it works for 85% of the population, let's not care about the other 15, those kinds of thinking. Issues of concern to the individual, of course, because nursing will never let that one go. Complex adaptive systems and intersectional influences, multiple things going on all at the same time. And those tend to be obscured by the traditional forms of thinking about an evidence agenda. So qualitative research comes in to try and challenge and disrupt some of that. There's a few little pitfalls that I'll mention, and I can't go into great depth about it, although there's lots to be said about all of them. But if we don't pay attention to that nursing epistemology along the way, we get stuck by things like assuming that there needs to be a theoretical framework in a qualitative study without asking, what would a theoretical framework privilege and what would it obscure? Because any theoretical framework you want to take up will obscure certain aspects. And that rule structure that came from social science does not necessarily work for us. In fact, it can turn that research into something else, into contributing to the theory rather than using a theory in a manner that works for us in nursing. Your educators, you would never train up a student to take only one theory into the practice context. In the course of their education, they will encounter all kinds of theories and ideas, and you would expect them to take a number of ideas into that practice world so that when the occasion arose, they have that close at hand. They can draw back on that theoretical idea and make sense of something. So nursing will always live in the world of multiple theories. And instead of a theoretical framework, you may begin a study by acknowledging the 2 or 3 ideas that seem most likely to be useful along the course of a study, but you're not predetermining that they will be used in a particular way, or that any other theories may not be brought in along the way as you start to see the need. And you're also thinking about, positionality yourself. What are those ideas that you bring in? What are the socio-cultural identities and disciplinary lenses? All of these ideas come into the course of a study, but they're not predetermining the outcome. You're critically reflecting on them throughout the whole study, because any one of them too can create that thing that the ableist language, there really is not a better term. That's maybe one of you can invent it, but that intellectual blind spot, the thing by virtue of attachment to being a nurse, for example, that we might not see. So, what is it that we obscure by virtue of any of these other positionings? So where I'd say is that nursing is the dominant positioning that we would always take. These others are part of the peculiarities or particularities within that nursing lens that we're taking into our work. And we do that making strategic decisions. What do I pack in my suitcase as I'm going into this study? Which are the ideas that I'm most likely to need along the way? And I'll articulate that as I move forward. Lots of issues that can go wrong in terms of data analysis, particularly if we take literally some of the ideas that come from mainstream qualitative literature, including thematic analysis, which is ultra popular as a technique, and can be used incredibly simplistically with very simplistic framework, and obsesses itself about codes and themes within a data set. So saying, how do I display a whole data set is not the question a nurse would be wanting to ask. The what can I learn from this data set is an entirely different question. And we'll focus our lens on those aspects that actually generate learning rather than characterizing a whole. Sandalowski referred to this in her great article, Words That Should Be Seen But Not Written. So the work of coding and thematizing and organizing is the homework we do in presenting excellent qualitative findings. But it's, saying I found 14 themes in 6 categories is not itself a finding. It's just telling somebody you did homework, and it's not the thing that's ever going to make your findings exciting. Your findings are exciting when they become a coherent narrative account that stimulates people to say, yes, I see how that fits. I see how that works. That makes sense. You're drawing your reader of a qualitative report along a set of findings. Another one that I'll mention is the idea of saturation, which got baked into qualitative methodology and reporting schemes and reviewing schemes, so that nurses are repeatedly saying, I interviewed people until I'd reached saturation, or they're saying until I reached redundancy. That kind of idea, although it makes some sense in the conventional world of creating brand theory, it makes no sense in the context of nursing. You might say, I've talked to a dozen people who have this shared phenomenon, and I've learned something that I think is worth reporting. That's authentic. But to say I've interviewed 12, and I now know that if I interviewed another 12 or 100, I wouldn't learn anything new, is disingenuous and underrepresents nursing creative imagination. So we're encouraging that people recognize in applied research, we have to have different aims than would the theory building world. And therefore, the way in which we make claims about sufficiency of data have to be quite differently articulated. And Malterud and her colleagues' stuff on information power is a perfectly good one. Have I gathered enough data to have something that conveys a sense of information power that will speak to the audience that I had intended? She's a family physician in Norway and has been working on qualitative methodology. So this kind of referencing is far more authentic than the idea of I've reached saturation. So the goal with qualitative research, and I think this is where nursing ideas have been pushing the work that I've been doing, and lots of other people are doing this. This is not a solo exercise. There's lots of dialogue and conversation in the applied qualitative world. But we want to engage in research that will help us actually see something differently rather than just go through a reporting exercise. And what's fascinating to me is that although I initially
好像去
thought
脱
of
裤衩了。
I initially thought of this as an entirely nursing enterprise, and that the methodology would be only of relevance to nursing. The basic idea of drawing on discipline and using it to develop design decision making has been taken up by a lot of different disciplines, and these are just a few of them. Some of them really quite surprising. I mean, I had an anesthesiologist turn up at one of my recent workshops, and I thought, I would never have picked anesthesiology as a place that this human, complex, messy stuff would make sense. But that many disciplines are starting to recognize that they too need to be able to justify design modifications that align with their epistemological reasoning. The key, and this is just a quick summary for those of you who may have no idea what interpretive description actually is. It's not a prescriptive method. It doesn't tell you you must do this and this and this, but it's inviting a direct line of sight between, on the one end, the research question, and on the other end, the intended audience. So where do you start and where do you end are in your sights the whole time. And then the design decisions that are made along the way are made using that nursing disciplinary epistemology with some guidance from some of the technique that has been generated through the long tradition of social science and applied health research. So you sample what makes sense to your intended audience, not just because somebody else did it that way or the text said it. You think critically about exclusion. In nursing, when we're studying something, if a person volunteers for a study and says, well, I don't quite fit this because I'm, a little bit more than 3 months post-diagnosis, we don't say I'm not interested in your story. We might say I'm interested in your story, and then I'll use my discretion as to whether there's some aspects about yours that I would interpret differently. So we look more broadly instead of narrowing things down. We engage with data collection in a manner that's authentic to our reason for doing research. So we don't just read off a standard set of questions and make them identical to all people we might interview. We'd follow the leads and respond to cues. We would use our professional reasoning, staying true to that disciplinary epistemology of why we are asking these research questions in the first place. So these are just some examples of how applied qualitative researchers are able to take up some of the tradition, but use it in a manner that stays true to authentic design decisions. We also are careful about using language, so we don't say things we don't mean. We don't throw in the word saturation just in order to meet the requirements of a journal. Instead, we say, no, actually, that's not. We're not ever saying we've seen it all or we understand it all. We're not understanding that the point of the world is to create themes. The thinking about themes might be one of the things we do in working our data in order to be able to find something. So we try and stay true to the using language in a manner that's authentic to how we think and how our audience thinks. And we certainly move beyond any of these methodological traditions that are along the lines of recipes, particularly those coding recipes. So we don't exhaust ourselves doing those and then having no intellectual space left for actually critically reflecting on what might constitute findings. We're engaging in a purposeful kind of analysis that says, what's here that I didn't expect? What's different in some way? What's similar and what's different? But most importantly, what story is emerging from this material? These things I've had a chance to observe or to listen to or to engage with during the course of my study. What story is emerging that deserves to be told? And that is the story that will shape the findings that are going to be relevant for your intended audience. And then taking all of that, we write it into a beautiful read. We try and create a set of findings that will draw in a reader to say, oh, yes, I understand that. I can see that. I see how that fits. I can imagine that in the patients that I've had in the past, but didn't know that in particular. And can really help us think about those clinical commonalities and differences that we will encounter. Or if it's an educational context, you'll help us understand those students or those student experiences in a different way. And we write it as a beautiful read, not as a technical report. And then take our findings out into the world, because they were intended from the outset to be applied. They were intended to be able to reach out to those who are struggling with having to do those things, to take care of those patients, to make those decisions in the everyday moment, and to give them some courage and confidence to be able to use that creative brain, to be able to understand how in an evidentiary context, some of those variations are absolutely justifiable, for example. And this might involve, certainly publication and presentation, but going to nursing rounds, going to team consultations, getting involved in standards, best practice standards kinds of exercises to be able to think about how to engage this in the rest of the world. Because I am absolutely convinced that the world, not just our own discipline, but the world actually needs an awful lot more of what can be learned qualitatively using that nursing disciplinary epistemological lens. So I'll close it up there, and I'm hoping that you'll have some questions after my whirlwind. I'm glad it was recorded because I realize I do speak quickly, and it is a topic about which I get quite excited. But I hope you'll take away from it that nursing lens, the way we think as nurses, really can start to shape the way something like qualitative methodology in applied health can be taken up over time. And it's not just something we do for ourselves, but it actually makes, I think, a contribution to the wider world.
Fantastic. Thank you so much, Dr. Thorne. We're seeing lots of claps and hearts and things come up in the chat. So I think your presentation is very much appreciated. If anyone has a question, as I say, please enter it into the chat or just write question if you'd like to verbalize your question, and we'll be able to recognize you. It's simply because I'm afraid I'm going to miss the little hands that come up with the number of people who have joined us. So.
While
Does
we're
anyone?
waiting, I could just mention that I've just pushed the send button on the manuscript for the 3rd edition of the interpretive description book. So I'm very hopeful that that will be out next year. And it has taken up so many of the questions and comments and from the various workshops and various presentations, people who've communicated with me. So there's no question that this is not a static issue, it's an evolving issue, and that all who take up this method and work with it are contributing to that project.
That's fantastic. So you've answered one of the first question that came up was about an updated version. So fantastic.
It is. And the other thing I could say is I've recently discovered, to my great delight, that I can make arrangements to have that made open access. So that's my goal, is to publish that book so that it'll come out in the paperback the way for people who like the paperback, but the electronic version would be available on an open access basis, which excites me no end.
That's fantastic and very generous. So if I can just call upon Karen Campbell. Karen has a question.
Thank you. Thank you, Sally. That was wonderful. And every time I have listened to you speak about this, I see it evolving, and I love that because I learn something new every time. Um, I just wanted to ask you your thoughts about the discipline part. So you talk about nursing discipline, and then you put up your screen with other disciplines like ECE and teachers and police officers and lots of other people using applied methods. What do you think about methodologists, like researchers that don't have a disciplinary background, wanting to use this type of approach?
Great question. Yeah, I actually think it's harder for them to do that, but often they're aligned with scholars who do bring a disciplinary lens. I have a lot of concern about us training up generic health researchers who just have technique, but don't have the why are we doing research? What's the motivation? So they're opportunistically looking for questions, which I see as quite different than the discipline of nursing. When I look around over all my years in nursing and look at all the things I've read, the things I've heard, the students and colleagues I've engaged with, they are doing something because they believe in something. And there's an awful lot of thinking behind that generating. So I do think that the ideas of interpretership can be useful without that, but that it does need to be directed by somewhere. We don't want just people out there who are doing technique and generating things without a purpose. In fact, that could actually be a little bit dangerous. So I would encourage those folks to be engaged in teams so they can borrow some of that disciplinary lens. And collaborative teams work very well. I'm also not an isolationist in nursing. Almost all my research is in collaborative teams with physicians and all kinds of other colleagues, epidemiologists and social workers and all kinds of people. But I think that it's probably very likely that the essence of my nursing lens is always part of what would be generating some of those directions. And it doesn't mean I need to be the boss and need to own it all, but that motivation is very much there. And I think in the social science world, the discipline's kind of written out of it or implied. It's kind of bad form to me to be saying in that context, I'm writing it from a nursing lens, like go try and publish something in social science and medicine saying I'm doing it from a nursing epistemology, and you'll see in the reviews what kind of response you get. That's just not considered a methodological strength.
Thank you so much.
Fantastic. Thank you so much, Karen, for your question. And we'll go on to Dion Sinclair. Would you like to ask your question?
Yes, Sally, thank you so much. This has been phenomenal. I am a PhD student at Western. I am completing my proposal, and I was looking at the experience of Black nurses who transition from the bedside into leadership. But you said, what can I learn from the experience of Black nurses? Right now, because I'm focusing on that one particular group, can I extrapolate to other diverse nurses or just that group? That's what I was thinking about.
The interesting thing is it depends how you go at it. You can see the difference in that question, Dion. It's a great question. If you say, what is the experience of Black nurses? You've started with the assumption that there will be a singular experience. But if you shift the language to say, what can be learned from the experiences of, then you have that capacity to then demonstrate some of that diversity and perhaps give a richer set of findings that could show what makes it work when it works well and what makes it work when it doesn't work well, that kind of thing. So you've opened up the question away from that traditional, more phenomenological kind of design. And then once you've set that question, the interesting thing is that sometimes people set a question in the old conventional style, but in their mind, they realize later on they've been thinking as if they've set the question differently. So you try and keep that alignment and word it as closely to what would make sense. If you think in advance that there's a singular experience, then that's probably what you would find. But to open it up and to say, I'm going to look more broadly. And then actually, I would say that you can't know. If you say talk to 20 such nurses or whatever number, you can't know until you've developed a sense of the shape of those findings and the insights that have been gleaned from the opportunity, the distinct opportunity you've had to reflect on and to probe and to ask more questions and to get a really, really rich sense of that, it's only in the context of the findings that you'll be able to make sort of a thoughtful extrapolation of saying these aspects of it may be applicable to other groups.
Yeah.
And I think that's a stronger claim to make on the basis of the nature of the findings than it would be at the beginning. So it's a great example. Thank you for raising it. And the other thing that your example points out is that so often, like others of you may be in the middle of a PhD program as well, or working with students that are partway through something, and it is not at all uncommon for people to take up another kind of method, to start into it and then get partway into it and find they're fighting with it. Or partly developing a proposal, but they don't want to do something exactly the way the tradition says. So interpretive description becomes a license to make those adaptations. You might say, I'm doing a narrative inquiry methodology, but the interpretive description is giving me license to make this modification that I've now realized I need to make. The goal is to really keep that nursing brain operating throughout, rather than saying, somebody's told me what I have to go do. Now I go do it. And then I struggle to say, well, what are the findings? And I end up just saying I found 14 categories. Yeah, you want findings that speak to the field. And I want to read those findings when they're done.
All right. Thank you so much. This has been very, very helpful. I appreciate it very much.
Thank you so much, Tiana, and best of luck with your research and your PhD. We'll be thinking of you. So we'll go on to a question that's been written here from Melissa Hay. Melissa asks, can you please speak to your perspective on bringing in pre-existing theories within the analysis or presentation of findings while ensuring analysis remains inductive and data-driven?
Great question again. I think that if you've named a theory at the beginning and said you've got a singular theoretical framework, and then you organize your findings according to that framework, you haven't really found anything. You've organized something. And so if you've started off with one or more ideas that possibly could be relevant, you've got much more license when you get to your findings and your discussion and your interpretations to be able to demonstrate at that point how that theory may or may not be helpful. And you can do that with a critical lens rather than sort of plunking in the ideas. I think that the risk with a theoretical framework, especially if you're a newer researcher and you're not confident, is that the easiest thing is to take the three categories of things that framework might say and then just organize your data according to that, which is not actually using that inductive reasoning process, or not using it to its full capacity. So I don't think there should be rules against how nurses bring in theory, because in fact we find theories quite useful in many aspects of our thinking about practice problems. Theories, philosophies, there should be no limit on how we draw on ideas, new and emerging ideas, ideas that disrupt historical patterns of thinking. All of those could be relevant, but I'd say that there's quite a difference between saying I'm doing a critical feminist study on something or other, because we know for sure you're going to discover that there's power imbalances in whatever you're studying and that they're explainable by gender, because that's what the theory has told you to be going looking for. So it's not really very exciting for you to come up with that finding. But if it is one of a number of possibilities that you're using along the way, and you're not dominated by that theoretical perspective, then those findings that you come up with may actually be quite plausible and credible to your applied reading audience. So it's just a sort of different twist in how we use theories, not banishing them totally.
Thank you very much. I appreciate that.
Lovely. Thank you, Melissa, for your question. So we'll move on to another question, but before I do, I see a hand raised. Again, if you have a question, if you don't mind, if you want to vocalize your question, just write question in the chat box or type in your question and we'll make sure we'll get to it in order. Thank you so much. So we'll move on to Haroop Sharda. I hope I'm pronouncing that correctly. The question is, do you think there is value in teaching philosophical traditions in undergraduate nursing education? If so, how might this affect how education is presently delivered at this level?
Yes, I do. I really do think that and I don't know whether that philosophical questions in the question means methodological traditions and theoretical traditions as well. But I think that undergraduate nursing students really do need to be exposed to the how interesting the ideas of nursing have been and are. And I don't think that's quite the same as sort of giving them one theoretical framework and saying we learn its minutiae. But to be able to learn something of the ways in which nursing has used theoretical thinking and philosophical thinking and methodology to be able to make advancements in its science and in its capacity to make a difference in the world. I think that if they don't enter into undergraduate education, then you're really missing an opportunity for those many who will be inspired by the idea that that's where that could go. I also do think that in the undergraduate program, we need to be thinking about priming people for not that you must go on to graduate education, but to help them understand what graduate education is all about and how it would allow them to deepen their ability to think critically about these issues, use ideas for work in the world, such as policy work, such as influencing ideas in their practice context, such as being better engaged with patient advisory groups, whatever aspect of practice they're interested in, so that so they understand that it's not simply going into graduate school because you hate nursing and you want to be a researcher instead, but that there's something that you love about the possibility and the ideas that graduate school can provide you with different tools and capacities to be able to enact them.
Thank you, Dr. Thorne.
Thank you so much for your question. So we'll go on to Grace Bowery's question, which is for new nursing graduate students, how do you suggest starting with the interpretive description method?
Yeah, I think conventional teaching, some years ago would say that it would always be better to learn something like grounded theory first, do a grounded theory study, and it's only on your second or third piece of research that you can make those modifications. But having worked with loads of graduate students over my career, I am convinced that with people who know how to think nursing and are fascinated by nursing, you don't shut off that nursing brain. And so to force fit into a methodology that is not quite working for you, and all power to those of you who are able to work effectively within conventional methods. I mean, that's another option, because many nurses will say, I'm doing grounded theory, this is a grounded theory study. But I could look at it. If I looked at a conventional sociology grounded theorist, they might see lots of flaws in it, but we can see the value of it in nursing. So people do get away with calling things that don't quite fit the traditions. And it's much looser, of course, than it used to be. But I am quite convinced that beginning graduate students for their first research project can very easily take advantage of interpretive description. I think it's very good if they have had some exposure to what the other main methodologies look like, ethnography and grounded theory and phenomenology, for example, many more. It gives them that sort of breadth of how you might go about thinking about what's data and what I'm going to do with it, for example. But it is certainly possible either to use interpretive description as a methodology as a whole, meaning you're going to be led by nursing disciplinary reasoning in creating those design decisions, or to combine it with another method. If you look at Dion's example, for example, about the experiences of, which is kind of like a phenomenological question, there might be no reason to say that it's got a phenomenological sense to it, but I'm also taking up interpretive description to explain some of the things that I'm going to be doing differently.
Fantastic. Thank you so much. Thank you, Grace, for your question. So we'll go on to, oops. There's so many questions popping up, it's moving my place. So we will move on to Ruina Rana, who has a question regarding, well, first says, thank you for your wonderful presentation, Dr. Thorne. They say, I'm a PhD student at TWU, and I wonder how we write proposals that utilize these principles but are still convincing to REBs and granting agencies who are often looking for strict adherence to specific methods.
Yeah, I think if in an ideal world, a smart nurse could just be saying, this is what I'm going to do in my study and not use any methodological reference whatsoever, because it is my disciplinary logic that's telling me how I need to follow this. It's like the intellectual curiosity you use in clinical practice. You've got a puzzlement and you're reading and you're talking to people and you're trying different things and you're working it all out. And that is what research can look like, guided by nursing epistemology. But no, you can't get through an ethics review board that way, for example. You can't say, I'm going to talk to people until I think I've heard enough. You need to have an estimate of how many people. So we need to live in the world of rules. But I think it is absolutely appropriate to make sure you're making the choices that make sense logically to the kind of question as you know it. You start into a study in an informed way. You've asked the question because you know enough about it to know that the question is worth asking and that somebody out there needs to have that answer. And so to use that as your primary guidance, there's no question that having a reference point and indicating that this choice is legitimate. For example, if you make a decision, some reviewer might say, somebody should always do member checks. And you might say, well, for my particular study, that convention of member checks is not going to be relevant for this reason. So it's always helpful to be able to have a reference point. And that's the value of having the textbook, which is why I went into writing a textbook in the first place. So people would have the reference points for the good logic that they wanted to exert. And by adding what looks like a credible reference or another study that did the same thing, then that helps you get through. It shouldn't be that way, but it is the real world that having credible references does help solidify the credibility of the argument you want to make.
Thank you.
Fantastic. Thank you very much for your question. We'll move on to Dudette, who would like to ask a question. If you're still with us.
Yes, I'm still here. Thank you.
Lovely.
Thank you for recognizing my question. Hi, Dr. Sally Thorne.
Hello.
I'm using your methodology for my research as well, and I'm at the point of data collection. So I am going to be probably finding information that might have things that are, not everyone has the same pattern or themes. I might find some outliers. And I want to find out, how do I account for those outliers as being meaningful? Like, how would I say that? Let's say it's just one and I try theoretical saturation and try to find more and still didn't find the same thing. Like, can I put that in my research, and how could I say that's meaningful? That's just something I want to find out.
Yeah, that's a good example of where the idea of saturation is not your friend, because it's putting you toward thinking the only thing worth talking about as a finding is something that was common among all people you interviewed, for example. But an outlier if you think about a nursing epistemology, and we share knowledge among each other by telling stories all the time. We say, I had a patient once who, and everybody knows exactly what you're talking about. You're not trying to prioritize your patient, but you're showing a variation, for example. And I think that the outlier is a reminder that the data set you have access to may not be the totality of what's out there in the experience. It may be an example of one kind of an outlier that causes you to think. And a nurse who has familiarity in a field will be able to, in an informed way, imagine what many other kinds of outliers might be. How would it be for a patient who was nonverbal? How would it be for somebody who'd had certain kinds of traumas? We're doing this all the time. And so even if we don't see all the possible diversities within our sample set, we have that disciplinary knowledge to allow us to critically think about the way in which we shape our findings. So we don't create inauthentic findings that sound like all people have X experience, when we should be able to know that there are many other kinds of experiences that people like those in our sample might be having. So the outlier can be your friend in that way, and a reminder not to present your findings as if the human beings we're studying are a unitary whole.
Okay, now I get it, because when you said earlier that it's not fixed, it's evolving, that
Yes.
evolving piece is coming up. Okay.
Well, that's the problem with thematic analysis and saturation, which are two pretty ubiquitous ideas in qualitative research review. They're hard to get rid of, but they are both challengeable. Once you understand what the problem with them is, then you can create alternative reasonings.
Okay, thank you. Got it now. Thank you.
Thank you so much. I know we're at the end of our time. We have a few more questions in the chat. I don't know if we want to address them or ask for individuals to try to contact you with those questions. John, maybe provide some guidance in terms of how we normally handle this.
Yeah, we usually do need to end on the hour, just for various, including maybe Sally's own time.
Absolutely.
So I think we really do need to stop.
I am easily reachable, Sally Thorne at ubc.ca. So you can Google me and find my my email address fairly quickly. If I know Nishana's hand was up, for example, and I didn't get to everybody, but if there was a question that is still not answered by somebody else's question, I just want to thank you all for taking the time to be here this afternoon.
Sally, there were a couple of, sorry, Sally, there were a couple of wondering about the slides. So I mentioned that CASN doesn't automatically send out slides or presentations, but they can connect with you if then you can determine if you want to send them or not. So just wanted to put that out there.
And people will have the recording, so that
yes, correct. That's correct. Everybody will get the recording. Yes.
Yeah.
Fantastic. Well, we just want to say thank you so much, Dr. Thorne, for joining us today for that fantastic presentation and engaging in conversation afterwards, answering so many questions. We just want to, again, reiterate that the recording will be sent out to everyone who has registered. Please feel free to share that link with all of your networks. And just thank you all for registering and for attending today, asking those fantastic questions. And we invite you to consider joining us for our next Lunch and Learn on December 5th, when Dr. Anthony de Padua from the University of Saskatchewan will present Exploring and Better Understanding How Homelessness Can Be Better Addressed Through Nursing Research and Leadership. So thank you once again to everyone who joined us today. Thank you again, Dr. Thorne, and I wish everyone a very lovely rest of your day. Take care, everyone.